thanks very much. Thanks very much for inviting me. Yeah, I sort of got into this area through the back door, really, and well, it may not be a good GI joke, but anyway, I came into it really without knowing it. As in most things, if you're a good clinical investigator, you listen to your patients. Most of the research is done by asking clinical questions that your patients have told you have not responded or not doing well, and you haven't sort of fulfilled their expectations. So you wonder, what else can I do? And what am I missing? And so this began to evolve in my practice, and to the point that, you know, as I told the medical students, even a medical student could have figured this out. There was something going on that we were not appreciating. So I'm going to talk to you about an area that is permeating GI, and it's probably present in most other subspecialties as we begin to appreciate the spectrum. So, first of all, hypermobility syndrome alone is common. I teach medical students at many settings, and they delight in showing me some of these signs that I think were very important in my clinic. They'll be able to do the hypermobility tests that I'll show you. So, you know, it's not maybe as high as 10%. Some people quoted 10%, so I took it. But these exercises, hypermobility, history that you've had joint dislocations, that you're hypermobile. These are not unusual characteristics that normal people can have. It's more common in women. It's more common actually in African Americans and Asian populations. That's not been as well quantitated. But there's then the question of, am I connected to something bigger? It's like if you go around in a room and shake hands at a cocktail party, 10% of the women have cold hands, cold feet. I don't touch their feet now, but that's not appropriate apparently. But so you might wonder out loud, gee, should I ask you any more questions? You don't. But could she have dry mouth, dry eyes? Could she have early scleroderma? She's got Raynaud's. Many people never go on. You stay happily with bed socks and gloves at night in bed with Raynaud's syndrome. So here we wonder whether some of these folks with hypermobility syndrome ever move into the bigger world of Ehlers-Danlos Syndrome, Marfan Syndrome, and osteogenesis imperfecta. There's a family, and with genetic testing and all the customized medicine we're doing, you'll be able to tell your children, yes, you may go down those roads, the door's open, but you may never take that path. You may just stay off on the main road and not take these exits. But these are exits that can happen genetically when you come in with hypermobility syndrome. So if you take the Ehlers-Danlos Syndrome exit, then you're moving into a much more difficult world of a connective tissue inherited disease, skin hyperflexibility, joint hypermobility, tissue fragility. Rare, but there. Many subtypes that can be more concerning than the sort of benign hypermobility syndrome type, autosomal dominant or recessive. The most common type of all these subtypes is the hypermobility syndrome. The vascular type, aortic dissections, these issues you hear about in younger people unexplained, are the more dangerous vascular subtype. And this just goes down the list that you need to be aware of, because hypermobility gets a lot of press, but there's a lot out there, particularly the vascular subtype we talked about cardiac valvular subtype. So, these are the football players that are at practice one day and suddenly running for a ball or something, and that's it. Could be a cardiac valve issue, it could be a congenital QT abnormality, but something's happened acutely in a very fit individual. These are probably missed worlds of Ehlers-Danlos Syndrome. In the cardiac world, the corneal and the areas of ophthalmology are also beginning to catch up. So this is, one of my GI fellows dug this up for an article we wanted to write. So apparently this was discovered, or she discovered it, in her readings as maybe the first evidence of a hypermobility syndrome person in a prone position. Here, in a very unusually hyperflexible situation, 1st century BC, which could be accused, or she was able to convince me, this was the first historical hypermobility syndrome. Probably the first case report we tracked down was somewhere in the 1870s. It was actually a man, which is uncommon, or less common in this world. So in my GI clinic now, when I see a female, usually a young female, who comes in with miscellaneous symptoms and we can't really put them in one place, we convince her to go through a number of gymnastics. Sometimes the mother wonders whether she's come to a gynecologist or a gastroenterologist. But putting your fingers back, that's the big one, is putting your finger back here on your forearm, and doing these kind of activities. Maybe we don't go to that extreme, but this is not, as I said, uncommon. I have medical students who show me that with great delight every day, and they're quite normal otherwise. But in my office, you're not normal until proven otherwise. So you're going to go through some gymnastics. We're going to ask this question early on, particularly if you come with, a huge folder of tests you've had up the gazoo, you've been to the Mayo Clinic, you've been everywhere, what's going on? This may be what's been going on all along, underappreciated and underdiagnosed. So we would ask you to see if you could figure out your Brighton score. And this is tricky. It's the Brighton score, but it's based on the Brighton Criteria. And what you don't want to have, and this happens in medicine all the time, it's sort of like a touch of pregnancy. We don't accept that. You either have it or you don't. And this is one of the problems in medicine. Everyone's got a touch of something. That drives me crazy, and we don't allow it to happen. You either have it or you don't, and we move on, because this asterisk just becomes untenable. And it's not a CPT code, luckily, so I can't bill for it. So you're not going to have a touch of it. So you either have it or you don't. So you have to show me something. So we're going to have you do some of these things that might get you a Brighton score of 4 or out of 9 or higher, based on those activities. Major criteria may be arthralgias that have been unexplained in 4 or more joints for 3 months or longer. Then we have the so-called minor criteria, which might get you in the door for further discussion, particularly the Marfanoid habitus, the tall, slim, long-spanned individual, prominent jawbones, prominent face. One of our recent Olympians you may recognize, won a lot of gold medals. He has a Marfanoid type picture. Skin striae, abnormal scarring. The drooped eyelids could be a variant of myasthenia gravis, drooped eyelids, trouble swallowing. And so we go through that. And then we talk to the patient. And she usually has something in the world of the GI manifestations. And how does hypermobility syndrome get into the GI world? Well, because of its elasticity issues, we see a lot of problems with the connections, the diaphragmatic connections to the stomach, the way ligaments hold up the whole intestine, particularly the pelvic floor, which can easily prolapse. But what I see a lot of is the pain threshold, the elasticity of the smooth muscle in the GI tract. So when a patient comes to me with pain out of proportion to objective criteria, that's when lights go off and we start saying, gee, am I missing something? This is called visceral hypersensitivity. CT scans negative, endoscopies are negative, biopsies are negative, but doctor, everything is more heightened. Eating a meal is more painful, GI tract activities, bowel movements are more painful. What is this? How can you explain it? I'm getting into narcotics potentially. How can we address this? So we talk about the pain threshold is out of proportion to objective findings. We worry about disorganization, if you like, in the way the gut is held up, maintained in the GI tract, connected. And then the dysautonomia is proposed as a major contributing factor to what may already be functional GI problems. We can't explain everything in the world by Ehlers-Danlos Syndrome. We don't want to get into that. It hasn't come in 2 centuries later and so explains, 21 centuries later and explains everything. No, it often heightens what you already have. Irritable bowel syndrome, sprue, celiac disease, not necessarily connected, it's not necessarily all one thing. You can have 2 or 3 things going on at once in the GI tract, but this may heighten the presentation of some of those issues, and particularly the pain part of the presentation. So let's work through a couple of these in the time we have. So in the esophagus, we think about reflux and heartburn. And we worry about whether this connection here, called the phrenicoesophageal ligament, which connects you and helps hold up the top of your stomach to the diaphragm and develops this little angle here in the lower esophageal sphincter in the angle of His, which prevents you from refluxing and minimizes hernias, hiatal hernias. So more common to have hiatal hernias, a more lax GE junction or weaker sphincter, incompetent. When you lie down, bend over, particularly at night, lying in bed, you may wake up with heartburn, coughing at midnight, whether you've eaten dinner late at night or not. Then we have, do I have trouble here with emptying of my stomach as well, and can I go through the pylorus well, which is a little opening, little tunnel at the end of your stomach, which opens and is compliant and allows food to be pulverized to 5 or 6 millimeters and go through. So you may have more incidents of heartburn, water brash, which is a term for over salivating, sometimes coughing when the reflux comes up, saliva, and dysphagia, which is the medical word for trouble swallowing. Inflammation here may cause edema in my esophagus, and in the upper sphincter, here in the upper sphincter, the cricosophageal sphincter, cricopharyngeal sphincter, maybe I've got some spasm, what's called a globus sensation. Feel tight all the time. I can swallow, but in between meals I feel tight. Then upper GI symptoms. As I said, eating a meal provokes some discomfort. That's when you know you've eaten enough. We tend to slow down. Other people have a heightened sensation. They get full prematurely. There may be some problem with the way the food doesn't remain in the fundus. The fundus is not well connected to the diaphragm. It's lax, and food empties quickly into the lower stomach, and you get full and bloated, distended, uncomfortable, nauseated, premature satiety. That could be part of the syndrome. Dyspepsia, indigestion, have more burning. Maybe the food sits around longer. I've got slow gastric emptying. I may have idiopathic nausea. Even though my stomach could be fairly normal, I come in with idiopathic nausea. When we do a gastric emptying, as I'll show you, something's wrong. And the belching could just be gas which has been developed from lower down in the small bowel. So gastroparesis is one of my calling cards. People come in the name of that. As usual, we usually find other things as well, but gastroparesis is a big deal in the world of does your stomach empty. It's delayed gastric emptying in the absence of any mechanical findings. We scope you, we do scans on you, there's no blockage. Looks normal. Car looks normal. You can't drive it. When you change gears, things don't run well. When you eat a meal, the stomach doesn't get motivated, it doesn't get organized, the nerves and muscles aren't functioning. Cardinal symptoms: early postprandial satiety, fullness, nausea, bloating, abdominal pain, reflux, and if you get worse, vomiting, usually 2 or 3 hours after the meal. And you may go on to lose weight, become malnourished, dehydrated, electrolyte imbalance. Your glucose control could become shaky. You could become hypoglycemic, or if you're a diabetic, it gets worse. Hyper. Old food called bezoars stay in your stomach, and you may vomit to the point it gets into your lungs sometimes. Aspiration pneumonia. Not uncommon. 4% of the population in the United States. How common is that? Well, sprue or gluten enteropathy is 1 to 2%. Hepatitis C is 3%. Diabetes is 10%. So we're in that ballpark. Irritable bowel syndrome, 15%. That's the commonest GI problem we see. And these are young females. Functioning, raising families and working. And that's why it may resonate with hypermobility syndrome, Ehlers-Danlos. The same population seems to be in those offices of those, for those doctors. So then we say to the patient, I wonder whether you've moved from interesting hypermobility syndrome to Ehlers-Danlos even, or do you have this other character in your life called the POTS syndrome? Well, now again, we don't want to touch your POTS, okay? You either have it or you don't. Because that drives people crazy. When you come into the office saying, I'll get everything, doctor. We know you have it. So at some point, we have to find out. So there is a tilt table test, which you undergo. It's not stand up for a minute and see if you feel dizzy and that's it. No. Maybe 10 minutes. We want your heart rate to go up more than 30 beats a minute, maybe above 120. At the same time, there's the absence of hypertension. And there may be some symptoms. So this clinical picture includes palpitations, lightheadedness when you stand up, headache, and this overlaps fatigue, and the chronic fatigue syndrome sneaks in as well. In the history of this area, that's often been associated with unexplained symptoms. It's an autoimmune phenomenon in conjunction with multiple autoimmune manifestations such as Ehlers-Danlos, we've talked about, could be part of multiple sclerosis, could be part of Sjogren's syndrome, lupus, and Raynaud's, in conjunction with. So maybe alone, or you may look for passengers traveling with it. So when you have hyperimmune syndrome, hypermobility syndrome, and POTS, then you're really in my office in a big way. Because we worry then about what is your gastric emptying. The rate of abnormal gastric emptying goes up. Normal still occurs. Could have nausea, bloating, fullness, don't feel well. But 20% or more have delayed gastric emptying, so-called gastroparesis, and 48% maybe could have even the opposite, rapid emptying, what's called dumping syndrome. Food runs through me quickly, postprandial diarrhea, bloating, gas, borborygmi, noisy GI tract, and hypoglycemia, empty so quickly my glucose drops. I may feel like fainting after I eat. So when you call it idiopathic gastroparesis, abnormal slow stomach, why did it happen to me? Why was I chosen? Well, we have to explain to the patient, why were you chosen? We talk about a gastroenteritis entity, camping out, restaurants, food poisoning, an event they probably forgot. Diarrhea and vomiting for 2 days, we all do it. Go back to work, bounce back. Some people don't bounce back. Some people have a very significant, nasty bug that gets a good grip on your GI tract. You're in a state where you don't reject it well or able to overcome the inflammation quickly, and it causes significant damage to your neuromuscular function. And you're not the same again. You may go on to get gastroparesis, you may go on to get irritable bowel syndrome in the lower gut. Post-infectious gut issues are a very hot topic, Sometimes remembered, sometimes not remembered. We don't have markers. You can't get a herpes simplex antibody, herpes zoster, CMV, rotavirus. It's too late. 6 months later, we can't find any footprints. We have to try to put the case together. And the case could have triggered some of the so-called Ehlers-Danlos manifestations, or heightened the hypermobility syndrome component. So I see idiopathic women in my office, so-called idiopathic, meaning we have no reason to know why you're nauseated, why your stomach's slow. This now comes on my radar, and often comes on through hypermobility. There's another entity that's getting a lot of press in the world called the median arcuate ligament syndrome. This is where the celiac artery, which is the first branch of the aorta in your abdomen, is compressed by the arcuate ligament, and it compresses the celiac ganglion and causes pain out of proportion to what it should be. Everything's negative. So we do an arteriogram and your celiac artery is compressed. And then we look at functional disorders. Can't explain why you're nauseated. Maybe your stomach empties too quickly, as I said, from the top to the bottom. Connective tissue, are you a latent scleroderma patient? Or do you have a degenerative CNS disorder? Guillain-Barré, that has become sort of a more diffuse degenerative disorder. Early multiple sclerosis. Or, are you also surreptitiously either telling us or not taking opioids, which delays gastric emptying? And then, marijuana is good in some cases, but we have to be sure they don't take it the night before they have a gastric emptying. So you may think you're hungry, marijuana's great, I'm relaxed, I've got the munchies. In actual fact, your stomach is not emptying. So if we go ahead and smoke marijuana and I give you a steak, you will not empty the steak as well as you would have before you smoked the marijuana. So not many marijuana patients are gaining a lot of weight. In actual fact, their stomach emptying is slow, and it's actually a cause of unexplained slow gastric emptying. So we get a urine marijuana screen on all people coming in to get a gastric emptying study, or we'll be diagnosing a hell of a lot of gastroparesis. All right, so in the world of the gallbladder and pancreas and the sphincter of Oddi, the sphincter here, which is the terminus of the bile duct and your pancreatic duct. We do an ultrasound, your gallbladder's normal. We do a HIDA scan. We don't see gallstones, but we want to do a HIDA scan to see if you have a spastic gallbladder. That may be more prevalent in Ehlers-Danlos. The pain of sphincter of Oddi dysfunction and the pain of gallbladder is more heightened. That's probably a true assumption. Irritable bowel syndrome and small bowel problems. Well, irritable bowel syndrome is the commonest problem in GI. Okay, 15% of the world have it. Of the women in this room, probably 20% have it. You'll find out when you go to high school reunions and other reunions. Have a talk around the table. Irritable bowel is very prevalent. If I don't diagnose it every day, I'm missing it. By Las Vegas odds, I'm going to see it every day. In women under the age of 50 particularly. So this is alternating diarrhea, constipation, abdominal pain, postprandial driven, stress driven, not at night in bed, it's a daytime problem, and it probably is heightened by the Ehlers-Danlos world of visceral sensitivity. Now sprue, I put it in there to remind myself, sprue is not connected to Ehlers-Danlos or hypermobility syndrome at all. But you can have sprue, you can have reflux, you can have ingrown toenails, and you can have more than one thing. So we don't want to be connecting everything. They're present, maybe diabetic, but some of the symptoms are worsened by this syndrome. And then the potential here for constipation perhaps, because of a floppy sort of non-motile colon that's not well connected to ligaments, slow transit time, and then a pelvic floor disorder where the pelvic sphincter does not relax well and open the gate for the bowel movement, and there may be some prolapse, levator ani muscle, which is the floor of the diaphragm of your pelvis may be weak, and you may have a tendency to prolapse and not be able to evacuate well, leading in some cases to overflow and what's called fecal incontinence. So this is a quick snapshot for you in the time we have. What are the take-home messages from a GI guy? Well, it's common. Whether in its benign form or whether it's connected to the Ehlers-Danlos world. Multiple signs, probably half the New York Ballet have hypermobility syndrome. That's why they're good. You know, this is part of hyperflexibility, hypermobility, hyperathleticism. So it alone may not be bad, but it has the potential to be connected to other issues. For years we just thought it was a joint disorder. Now we know it has multiple manifestations in the GI tract. And I've tried to go through them. I think when I come across patients, pain is a big issue. Sometimes to the point they can't eat well, because eating induces pain. I've had to put people on enteral nutrition, feeding tubes in their GI tract. Even some pediatricians have gone to parenteral nutrition. Patient cannot eat enough to sustain nutrition. And POTS syndrome adds another dimension, particularly to the world of gastric emptying. So my take home as a practitioner is all of us need to become more familiar with this entity which is emerging into our practices. And in particular, patients where they're called idiopathic. We don't know why you're here and why these symptoms are occurring. We have to drill down and wonder whether we're missing that syndrome.